It's 12. Welcome to Grand Rounds for those that are here in the auditorium and those on Zoom. I'm not quite sure. And in any case, yes, welcome to Grand Rounds. It's a real pleasure today to introduce our speaker, Dr. Danny Ennis. There are many, many things I could say about Dr. Ennis, all complimentary. Dr. Ennis is a rheumatologist, as you know, specializing in vasculitis. Did special training in Toronto to increase his acumen in vasculitis. I first met Dr. Ennis when he was a medicine resident. Then he subsequently became the chief medical resident here. Went on to do rheumatology, as you know, and he has many layers of accomplishment, not the least of which is he hosts our podcast, St. Paul's Hospital Morning Report. So today's talk he's chosen is CNS vasculitis. So Dr. Ennis.
Hi, everyone. Just let me know if it's hard to hear me. So no relevant disclosures. And just starting off with the acknowledgement that we're gathered on traditional territories of the Musqueam, Squamish, and Tsleil-Waututh people. So I actually don't like starting with cases that much, but we do it anyways. And actually, Barry, I doubt you'll remember this, but I once presented a case of a really complicated arthritis. They had HIV and they had recent gonococcal infection, and they had lots of medication changes. And it was a really elaborate case. And in the end, I thought it was an interesting ending, but it just ended up being gout. And the point was that, common things are common. And I mean, you might remember it differently, but I'm 90% sure that you booed me. But so this actually is a case. And spoiler, it's something nasty. So 64-year-old gentleman, he has type 2 diabetes, hypertension, a thyroid nodule. He's on metformin only. He was born in Hong Kong. He's kind of a high-powered mortgage broker, no smoking, alcohol, or recreational drugs, and his daughter has JIA. So this is a few years ago now. So February to March, he starts becoming increasingly confused. He starts to show unusual behavior at home and at work, and his work is actually suffering. He's actually doing a bad job, and the partners in his practice are essentially like not clear what's going on with him. And it's unclear what's happening until he's admitted to VGH-in status. He has a CTA that's negative. He has an MRI that shows leptomeningeal enhancement around the inferior aspect of the temporal lobe. He has a lumbar puncture, which isn't like, it doesn't blow anyone away, but WBCs of 10 and protein elevated at 0.79. Glucose is normal synth rate, and no oligoclonal bands. He has a bunch of investigations, right? He has a bunch of autoimmune stuff, and he has a bunch of infectious workup, and nothing really comes back compelling. He has a perineoplastic and mitogen panel that come back negative. He has voltage gated and NMDA testing that's all negative too. And so the question at that point, you've done a ton of blood work, you've done good CT imaging and MR imaging, and the question is sort of like, well, what's next, and what's actually going to tip us over into a diagnosis or get us to a point where we've met a treatment threshold where we're comfortable saying, well, it's sort of easy to say, well, it could still be an infection. Well, sure, but we actually have to make some clinical decisions. And so what's actually going to get us there? So I'm going to jump in with just a bit of an introduction on primary angiitis of the CNS, or what we kind of colloquially call CNS vasculitis. So PACNS, primary angiitis of the CNS, this is idiopathic inflammation. It's of small vessels, or depending on what source you look at, medium to large vessels. So if you ask a rheumatologist, they're probably going to describe the named vessels inside the brain as medium-sized, because the aorta is large. The primary branches of the aorta are large. Everything else is medium or small. So we probably wouldn't use the language of this being a large vessel vasculitis, but radiology often does, and perhaps stroke neurology might say the large vessels. Doesn't really matter. Small versus medium and large. Also, leptomeningeal and parenchymal arteries are an important part of the disease as well. You can also get venous involvement, but we're going to leave that for now. So if you look at the Mayo cohort, which is centered in Olmsted County, the incidence is 2.5 cases per million person years. Right? This is really rare. So when we're on service and we get 2 to 4 consults of this a week, statistically, we don't even need to see it. It's not CNS vasculitis. But of course, there's other types of vasculitis we have to consider and other autoimmune diseases, but quite rare. Frequency, for what it's worth, seems to be similar between males and females. Median age of diagnosis is 50, but it actually has a really wide span, right? And there's pediatric CNS vasculitis we're not really going to cover, but it's an important diagnostic entity in peds. Presenting symptoms and the clinical course are variable, so making the diagnosis is really hard. And I think that's sort of where we want to center our discussion today. So this is just to orient our discussion. CNS vasculitis breaks down into primary or secondary, like all vasculitis, right? After you've diagnosed someone with vasculitis, the next question is always, well, is it primary? It's an autoimmune rheumatic disease, or is it secondary to a medication or an infection or a malignancy or something else that I haven't thought of? So when I talk about CNS vasculitis today, I'm primarily referring to primary angiitis of the CNS, right? The idiopathic disease. There are some diagnostic criteria. We're not going to get too deep into this, but it's not validated. It's not widely adopted. It is widely adopted, but not validated. And so when you look at various studies, they don't necessarily use these criteria in order to compose the literature. So the literature is inherently murky. So that makes it complicated to draw strong conclusions from some of the cohorts that exist. Essentially, the criteria are sort of, it looks like CNS vasculitis, it doesn't look like anything else, and you've ruled out everything in the universe. And so okay, that's sort of easy once you get to that level of specificity. There's this framework for CNS vasculitis that's come out more recently, 2009. And I think it's probably the language that we should use, which is, I think rheumatic diseases, you may have now bumped into this, sometimes there's a question mark beside it, right? So they're diagnosed with rheumatoid arthritis, but then some new rheumatologist comes in and says, actually, it's not, it's psoriatic arthritis. Oh, it's not that either. It's some kind of seronegative arthritis. That happens all the time. So we probably should adopt language more around probabilities of diseases, especially for diseases where definitive diagnosis is notoriously hard, like CNS vasculitis. So these guys kind of come up with the idea that if you biopsied it, then you definitely have it. Okay, that's actually not definite either. That just says that you have vasculitis. It doesn't prove that it's primary, right? But essentially, conceptually, you've ruled out other stuff, you biopsy it, it is vasculitis on the biopsy. I think that's a reasonable place to say definite. And then probable is for literally everyone else who has compelling clinical and radiologic and CSF profile. And then we also have, there's different ways to divide up adult primary angiitis. So the large medium group, as I mentioned, and then the small group. So large vessels and small vessels. Another way of saying that, it's an imperfect analogy, but angiography positive versus angiography negative. So for the purposes of this talk, that's primarily what I mean. When I say angio negative, I'm usually talking about these small vessel involvement. When I talk about angio positive, I'm talking about large vessel involvement. How would you have made the diagnosis of small vessel then if your CTA or your MRA is negative? Probably by biopsy. So that's important for how we interpret the cohorts that we'll talk about. We are going to more or less ignore childhood disease because it's a whole different topic. It's super important, but a little bit outside of my personal wheelhouse. So there are two main cohorts. So it's actually good news. If you want to become an expert on CNS vasculitis, there's only two major cohorts that you really need to wrap your head around. So there's the Mayo cohort and the French or Kovac cohort. So the Mayo cohort's kind of larger, 163 patients. I'm sure it's a bit bigger at this point. And they divide into biopsy positive and angio positive small versus large, angionegative versus angiopositive. These are sort of the same language, but they look a little bit different. So in their cohort, confusingly, there are some patients who are angiopositive, who they've still classified as small vessel. Just ignore that. Let's move past that. For the French group, 52 patients, there's biopsy positive and there's angio positive. Okay, so they kind of ascribe to the language that I want to use, which is if you're angio negative, then you're small vessel disease. If you're angio positive, you're large vessel disease. Okay, so just some clinical manifestations. Sorry, it's not that, maybe not that large for you folks, but this is important. There's no classic or pathognomonic presentation. And that's what's so frustrating, right? How do you establish a pre-test probability before doing testing for a disease that's extremely rare, that has variable presentations? I would argue that you sort of can't. Like your pre-test probability should always be like essentially asymptotically approaching zero. Like it's very unlikely. And yet we all periodically see these cases. Headache, so that's present in about 50%. It can be subacute or chronic. It's often severe and persistent rather than fluctuating on and off. It may be generalized or localized, but specifically, it should not be a thunderclap headache. That is language worth remembering from this presentation if you don't remember much else. Depending on cohort, focal neurologic deficits are seen in, somewhere between 40 and 80%. Diffuse deficits or cognitive impairment, 50 to 70%. Visual symptoms, about a third. And seizures, about a fifth, but way more common in children. Symptoms at presentation is maybe a more important way of thinking about the disease because that's actually how you're going to bump into it, right? So this is a comparative chart between the two cohorts. There's, the numbers are relatively small, so it's hard to kind of extract like, okay, these are the things we definitely know about the disease, and these are the things that we still have left to learn. We kind of have everything left to learn, but focal neurologic deficits seems to be a common feature, as does headaches. Cognitive impairment is common. And then what's not common? So it's not common to have intracranial hemorrhage. It's not terribly common. And it's not that common to have constitutional symptoms. So if someone's coming in fevering away and they look really, really sick, that's not that common. It probably reflects something else. So then maybe we try and figure out, are there clinical subsets? So can we figure out what sort of disease they're going to have, or what clinical course they're going to have if we look at histology, or whether we biopsied them or not, or what the blood vessel size is? Can we figure out how to treat them differently, or what their clinical course will be? There is some literature on this, and I've highlighted kind of the things that are statistically different between the different clinical subsets. We'll talk a bit more about clinical subset, but essentially histology breaks down into three groups: granulomatous, lymphocytic, and necrotizing. There are slight differences that you can find in the available literature. So this is primarily derived from the biopsy group of the Mayo cohort. And so there are some differences. So, so granulomatous, there's more leukocytosis on the LP. Lymphocytic, there's more GAD-enhancing lesions. Necrotizing, there's more hemorrhage. But it's not like, it's not 100%. None of this guaranteed. So it's not like you can look at an MRI and say, oh, there's actually hemorrhage on this, so it's probably necrotizing. It's not quite good enough to distinguish that way. And even if you could, it's not going to make a huge difference in terms of your treatment. It's not a huge difference, but there is one important distinction. So just remember these three groups: granulomatous, lymphocytic, necrotizing. Okay. How about whether you've biopsied them or not biopsied them? Well, the biopsy positive group, which is usually the only way to get the diagnosis by biopsy, is for those small vessel vasculitis groups. They have more altered cognition, they have more protein in the CSF, and they have fewer infarcts. So they're less likely to be the ones with kind of vascular territory strokes, which kind of isn't that surprising because they're the ones who are angio negative. The ones who are angio positive have a big stenosed MCA, let's say. Well, that person's probably going to have a stroke in the MCA. So not terribly surprising there. What about by vessel size, right? This is more specifically what we want to know. Let's say when you have a positive angio, does that dictate what they are going to look like clinically? And there are some, distinctions. They're not massive differences. You can look at the numbers if you like, but if you're angio negative, you are more likely to have cognitive dysfunction. If you're angio positive, you're more likely to have a stroke. So this sort of maps onto the same biopsy positive, biopsy negative concept. How about the things that they share? So headache's pretty common, but that's sort of it. Like there's a lot of heterogeneity, and that's a problem for us as we are trying to figure out what they have at the bedside. Just looking at the French cohort, just for comparison, it sort of has a bit of a similar overall picture compared to the Mayo cohort. They kind of, without giving you specific numbers, kind of giving you just like more or less concepts. Okay, so we went through this one at the beginning. This is probably where I look to determine, like, okay, if I have a patient in front of me, like, are these symptoms common or uncommon? If I look, okay, they have a intracranial hemorrhage, I'm gonna say, okay, well, that's a little less likely. Okay, how about fevers? It's a little less likely. All right, let's talk about diagnostics, because this is, I think, where the real internal medicine comes into play. There is no lab test that is specific. So serologic tests are not terribly helpful. There's limited specificity of your cerebral spinal fluid and angiography. It's difficult getting biopsies, and all those things together limit early and rapid diagnosis. One thing to know, as we mentioned, is that the likelihood that you're seeing CNS vasculitis, even if it sort of sounds like it to you, is low. You're probably not. It's probably something else. So blood testing, non-specific, but you kind of saw in that the case that we started with, there's a ton of labs that get sent, and it sort of depends who you ask. So if you call hematology, they're probably going to do a more elaborate workup for intravascular lymphoma or angiocentric lymphoma. So they're going to think about skin biopsies and flow cytometry and sending that large volume CSF for flow, things of that sort, or cytology. ID is going to cast a really wide net, right, for all the various bugs that could cause this. And rheumatology is going to send our usual stuff. Okay, this is important. An abnormality of some kind is relatively common in CNS vasculitis. So it's of moderate to high sensitivity. And what's probably important here is that whether you are biopsy positive or small vessel, or angio positive, large vessel, your CSF is going to be reasonably helpful. In pediatrics, it's sort of the opposite, where the LP is usually normal in the angiopositive group and usually abnormal in the angionegative group. But in adults, it's still a helpful test. The common things that you see, usually it's lymphocytic, you see elevated protein, you see normal glucose. So these are all comers, so all types of CNS vasculitis. So this is all smushed together, even though we've been talking about, there are some distinctions between these groups. So each thing individually. So, okay, elevated white blood cell count on its own, 50-50. Elevated protein on its own, 80%, that's pretty good. Elevated RBCs, 80%, that's pretty good. All of them together, so any of them, high white blood cells, high protein, or high RBC, had a 93% sensitivity in this cohort of CNS vasculitis patients, both large vessel and small vessel. But that is maybe going to confuse us. We really do need to look at the two different subsets, right? Because the patient in front of you is probably going to have one of those diseases, not both. So here we look at sort of the distinctions between the biopsy confirmed, the small vessel, and the angio confirmed, the large vessel. And there are some important differences. So CSF protein and leukocytes have reasonable sensitivity in biopsy-positive disease. If you look at the angiopositive disease, white blood cells, the sensitivity is only 40%. That's just not that good. So we know that for those angiopositive patients, you only get reasonable sensitivity if you look at any abnormality. If you have a perfectly clear lumbar puncture, it is probably not CNS vasculitis. That's as good as this test gets. And that's not that helpful, right? Because, I mean, if I do it, if someone asks me to do an LP, I'm definitely going to get some RBCs in there. So, I think that's kind of an important lesson. So just for comparison. So comparing biopsy positive versus angio positive, elevated protein is going to be 94% versus 70%. Elevated WBCs are going to be 70% versus 40%. That's not that great. Okay, there you go. So that's sort of the summary of CSF. Both groups have high levels of some sort of abnormality. And that's the best I could extract from these cohorts. So that's not that helpful. In the French cohort, just for comparison, they had a bigger split. So if you were one of their biopsy positive patients, small vessel, CSF abnormality was present in 100% of patients. Whereas if you were angio positive, CSF abnormality was 50%. So it does depend what cohort you look at. I'm primarily looking at the American Mayo cohort because it's larger. So don't be fooled by a negative CSF, but don't overinterpret a positive. So what about imaging? Is that really going to help us out very much? So often we see ischemic infarcts. That's the most common feature, and that's only about 53%. But an MRI brain is a very sensitive test. So if you have a normal MRI, they probably do not have CNS vasculitis. CT, MR, conventional angio are not specific, right? So it's a relative, MR is a sensitive test, but not specific. Conventional angio really should be a consideration in our testing. It does offer things that the other testing does not. It is distinct from a CTA. It can show, this might be the language you see, so beating, tapering of vessel lumen, fusiform dilation, multifocal occlusions, collateral circulation, delayed contrast enhancement, and washout. Those are that's language you might see. So, what else are you going to see? So ischemic lesions, we said, 50-ish%, depends on the cohort, but 50-ish%. And if they're there, they're usually bilateral. GAD-enhancing lesions, that's going to be in about 40%. Hemorrhage, upper limit is 33, but probably think of it more like 10%. Leptomeningeal involvement, not terribly uncommon, right? About a third. And tumefactive lesion, which is a form of CNS vasculitis, and usually these are the people seen by neurosurgery. They take out what they think is some kind of aggressive brain tumor, and the biopsy is just all vasculitis. That is a small fraction, but we do get those cases as well. So conventional cerebral angio, that gets you down to really small vessels, real small. But as I said, just because the vessels are tiny, if they're angio positive, we are considering them medium to large vessel vasculitis. Okay, so sensitivity is low. Specificity is low as well. All of the cohorts that we're looking at, they are enriched for these conventional angio diagnosed diseases. So all of them started in like 80s, 90s. So a lot of them are using conventional angio for the diagnosis, just to be aware of that. This kind of brings us to now though, right? Because now we are starting to wrap our heads around vessel wall imaging. So this is still an evolution. You really do need a good MRI machine. You need really well-trained neuroradiologists. And you've heard of like fat saturated imaging. Well, this technique is blood saturated imaging, also called dark blood or black blood imaging. So these are blood suppression techniques in the CNS. there's some promising numbers, right? So this is a number of studies that I found. It's probably a little bit specific to center to say the specificity is 94%. That's really high, and I'm not sure that reflects our kind of local experience with it. But maybe it's just experience. But this was actually a useful study, the first one here. So sensitivity was high. That doesn't totally surprise me. We know MRI on its own has a high sensitivity. Specificity was really high. All of the patients had multifocal vascular involvement. So it was not just one area. And this was a cohort of patients with known CNS vasculitis versus patients on a stroke ward without CNS vasculitis. So just general stroke patients. That is actually the comparison that we want, right? Only 4% of the general stroke patients had a positive vessel wall image. That is good. That is really important to know, that it's unlikely, in the right hands with the right neuroradiologist, we are unlikely to be fooled by a positive result. Great, that's really helpful. That doesn't, this one below it is from a number of years earlier. So kind of, what is that, 7 years ago? Sensitivity and specificity was a lot more poor. I think that might be the technology at the time. There was one study that looked at, if you have the MRA, what's your diagnostic yield? And then if you add on vessel wall imaging, what's your new diagnostic yield? In a cohort of patients with CNS vasculitis, it doubled the diagnostic yield. So there's quite a bit of value based on that. And then the most recent one, this Daniello study, that was just looking at sensitivity amongst a cohort of CNS vasculitis patients, and it was high sensitivity. So our more recent studies are suggesting that this is a very good test. This is just to kind of show you what that looks like. Sorry, this is a lot smaller than in the room here than I'd like it to be. But if you look at where the arrows are, let's look at the B image and C image. The B image is probably the easiest to see. There's a little white circle. And the key here is that this lesion is concentric or circumferentially enhancing. That is the important sign. So that is what we're looking for. When we're looking for, aortitis, we're not just looking for any thickening of the aorta, we're looking for concentric thickening of the aorta. I mean, this is definitely oversimplifying, but presumably if you have an immune disease that's attacking an artery, it doesn't pick like one little part of the artery, it's attacking the artery or it's not. And if it's attacking the artery, it's probably affecting all the parts of that artery, not just like the north part or a caudal part or whatever. So expect it to be concentric compared to, So this is a mimic, right? This might be a little bit clearer to see that on image 2, the top right, you have eccentric or eccentric vessel wall enhancement. This is classic for intracranial atherosclerosis, right? You've probably heard the idea of inflammatory athero. You see it clinically, right? You have patients like, oh, they're a terrible vasculopath, their CRP is always like 10. And you kind of just intuit that like, well, their athero is probably like partly responsible for why their CRP is so high. It's so high, but not terribly high. And I think that's the same here, right? It does not surprise me that this enhances. It is as expected that it's eccentric. It's not enhancing all the way around equally everywhere. So I think that appears to be a consistently useful tool. So we've kind of talked through a lot of this. We really, just because of time, we don't have a lot of time to talk about intravascular lymphoma. I think that's sort of its own separate talk. But let's talk about biopsy, because this, I think, is where we also start to get into a sticky situation where everyone kind of looks at each other and says, oh, geez, should we biopsy this person's brain? And everyone gets real nervous because I wouldn't want someone biopsying my brain. But what do we know about it? So biopsy is considered the gold standard. Like giant cell arteritis, it can be patchy. So the whole brain isn't necessarily inflamed, and you're not necessarily going to get a positive biopsy. So be aware, a negative biopsy does not have a good sensitivity. But biopsy is diagnostic, depends on cohort, but between 50 and 75% of cases. And diagnostic doesn't necessarily mean it's diagnostic of CNS vasculitis. It's diagnostic of a thing. That's really important, right? And I'll show you a slide with like other things to consider as mimics of CNS vasculitis. Typical findings, it's usually that lymphocytic subtype. Though recall, there's the granulomatous subtype and there's the necrotizing subtype. You see all sorts of cells in there, non-specific. But this study is so interesting, I think. So diagnostic value and safety of brain biopsy in patients with cryptogenic neurologic disease, systematic review and meta-analysis. This is a ton of cases. It is going to take us 1,000 years to get this many patients in a cohort. So it's not going to happen while I'm practicing that we get this many patients from the start. So this is an important question, right? If you have a cohort of CNS vasculitis patients, that is figuring out data in reverse. You've already established they have the disease and you're trying to figure out like, well, how did we figure that out? These are patients with neurologic something. We don't know what is happening in their brain. What is the value of a biopsy in these patients? And of course, there's going to be a lot of individual patient data that would probably be important to fully interpret this information. But I think this is valuable. One, this is a big list of other things that you might just not have even thought of when you are pursuing that biopsy, such as sarcoid. Did you think of sarcoid? I know Barry did, but did I? Maybe not. Lymphoma, right? You very well might have thought of that. So let's see here. So diagnostic success rate was 75%. And that is, there's the adult cryptogenic stroke. And then the second category is those suspected of primary angiitis of the CNS. So that's for me, right? When we're called, they're like, is this primary CNS vasculitis? And so this is kind of helpful for me. What's the diagnostic yield when I ask for a biopsy? So of the total cohort, 34% had CNS vasculitis, 9% had lymphoma. That is such a high percent compared to what I would have thought. That is a high enough percent that I feel I can make a very legitimate case that just because I think someone has CNS vasculitis and I'm supposed to be good at vasculitis, which no one can prove otherwise, it doesn't matter what I think because we don't know unless we biopsy it. Can we take a whack at it and give them medication? Like, well, of course we could do that. That's really easy. But if you had lymphoma in your brain, would you want to be on rheumatology doses of chemo, or do you want to be on targeted lymphoma protocoled chemo? That one, for sure. So the delay in diagnosis is a really relevant part of the discussion, right? If I'm wrong and they don't have CNS vasculitis, what have we missed? Well, there's a pretty big list of very nasty things that you do want to know about. Okay. So it seems to be of relatively high yield, but of course the other balance to that is how dangerous is it? And in this study of over 800 cases, morbidity rate was under 4%. That's not nothing, but that's important for us to recognize. And we do conventional angios with, I think, a lot more, frequency. And the morbidity rate there is just under 1%. Those aren't the same number, of course, but just to reflect that, it's a dangerous test. It's not without its own risks. When we ask neurosurgery at VGH, and of course it depends on, it's very case specific. So I'm sure any surgeon would look at this and say morbidity rate of 4% in a random group of people with neurologic something, I don't know how to interpret that. I'll tell you what it is on a patient to patient basis. And I do think that's fair, but we often hear oh, it's 10% mortality. It really shouldn't be. It shouldn't be 10%, but maybe just depends on the case. So just to summarize reasons you should consider at least pursuing a biopsy. It may, and in fact very likely, will identify an alternative diagnosis. Long-term immune suppression is dangerous on its own, and it may worsen the underlying condition if it's one of the things you haven't thought of. The wrong diagnosis will delay appropriate treatment. So this is why we should have the conversation early, even if we decide altogether not to do that, right? Like, I mean, I think it's pretty easy to lose your nerve to do a brain biopsy, and I don't think that's silly. It's just a conversation that should be had kind of with this in the background. All right, well, where do you biopsy? So you try and biopsy active tissue and the associated leptomeninges, because the meninges are often involved. So you might get good tissue from there. And then if they have kind of eloquent brain involved and you can't biopsy that, then there were a number of initial papers saying non-dominant temporal lobe, but more recent papers saying non-dominant frontal lobe, which is really what neurosurgery would be more likely to offer. And again, take leptomeninges with that. Just for time, we may kind of whip through the histopathology. I don't think it's like terribly interesting for you folks, but as we said, granulomatous, lymphocytic, and necrotizing. And there's low levels of agreement between histology and angiographic findings. So just because you see someone has large vessel vasculitis, they have a CTA, right? That's positive, and CNS vasculitis, you can't jump to the conclusion that you know what their histology is going to look like. These are just some pretty pictures. We'll kind of skip this. There you go, some nice pictures. Okay, so kind of down to business then is, does it matter at all if you figure out what the histology is? So by histology subtype, looking at response to therapy and remission and deaths, there's no differences in response to therapy by subtype, but necrotizing and granulomatous had better long-term remission rates than the lymphocytic variant. So that kind of gets us to, I think we have enough information to kind of talk about like putting it all together in kind of flow chart. Diagnosis relies on a combination of history, examination, imaging, lumbar puncture, and asking everyone for help, right? So I don't like doing this alone. I'm not an infectious diseases doctor, and I shouldn't pretend to be. I should ask for help. I'm not a neurologist. I should definitely ask for their input, right? Internal medicine, you folks always have good ideas. It's important to involve everyone. We should at least consider biopsy and angiography. Let's do a little bit of a run through some important mimics. So what are some red flags that you might want to be aware of? If you're younger than 40, consider RCVS. We'll talk about what that is in a second. If the patient's over 70, start to think about amyloid. If it's a basilar predominant inflammation, that's really where we see more sarcoid, fungal infections, tuberculosis. If they have a lot of systemic symptoms, right? We talked about across the two cohorts, it was relatively uncommon to have fevers, just as like one constitutional symptom. So consider a secondary cause. And in the immune suppressed population, infection, right? Infection, until you've ruled that out, that's the most likely thing. This is for reference. We're not going to go through each of these, but even when I see patients on the ward or on my own time in clinic, before I see them, I usually sneak to a computer and I look at this chart because I can't remember all of it because it's really complicated. And I at least need to have a peek through and be like, okay, got to remember these major categories: infection, autoimmune and demyelinating, malignancies, drug and metabolic disorders, and non-inflammatory disorders. That's maybe one of the most important, or more, it's maybe one of the more common groups that we actually bump into with relative frequency. And there's some really interesting diagnoses in here you may or may not have seen before. But maybe a more useful bedside version of kind of a similar list is like, okay, well, what has angiographic abnormalities, right? What's going to be angiopositive? What's going to have MR lesions, right? GAD enhancing lesions and stuff. What's going to have multifocal strokes, vascular territory strokes? And then there's the other category where I'm like, actually, yeah, I don't even know what's happening with this person. I should at least think about this unusual list of disorders. Barry, how many CNS porphyrias do you have? Zero. Okay. So far. Okay. I think that it's a really nice paper because it kind of addresses relatively like things you're going to see and kind of compares it in basic terms versus CNS vasculitis. Right. So we are going to spend a bit of time talking about RCVS because it's so important. But this is characterized by thunderclap headache, potentially seizures. There are some specific MRI findings. The CSF is usually normal, whereas we talked about in our patients, the CSF is usually abnormal in some way. And the arteriopathy, if you were to biopsy it for RCVS, which is reversible cerebral vasoconstriction syndrome, RCVS, if you did biopsy it, it should be totally normal blood vessels. There should be nothing wrong with the blood vessels. It doesn't mean it's not a serious disease potentially, but it's not an autoimmune phenomenon. Sneeden syndrome is kind of its own thing. It's associated with antiphospholipid antibodies. It's characterized by livedoid rashes or livedoid skin changes in the periphery and a bland vasculopathy in the brain that is gradually progressive, but may manifest as multifocal strokes and often does have abnormal angiography. ABRA, so this is amyloid beta related angiitis. This is sort of on the spectrum of CNS vasculitis, but we kind of group this as a separate type of disorder. We think of the amyloid disorder as kind of apart. And I do have a little slide on that. Sussex, right? This is primarily in typically young female. They have branch retinal artery occlusions. They may have sensory neural hearing loss, encephalopathy, and they usually have the classic central corpus callosum lesions. CADASIL, we're going to skip. This is an autosomal dominant disorder. Neurosarcoid can kind of look like whatever, but often does have cranial nerve involvement and may have basilar predominant disease and often peripheral involvement. It's rare to have pure CNS vasculitis. So just a little bit about RCVS. This is actually really important and it should just be on your mind when you're seeing a case. So these are reversible multifocal narrowing of cerebral arteries with thunderclap headache, and they may or may not have persistent neurologic deficits. They may present with seizure, ischemic stroke, subarachnoid hemorrhages, or even PRES. It is female predominant. It's typically young people. 60% will have an identifiable trigger. And so some of these can be, uncomfortable questions, but they're really important, right? So was it precipitated by vasoactive medications, any recreational drugs, including cannabis, pregnancy, or something situational like cough or sexual intercourse? So essentially, there's usually something that you can say preceded onset. I also usually ask about sometimes when people have a cold and they take decongestants, right? That can also be a trigger. All right, there is diagnostic criteria. Kind of the most important thing here is that they have multifocal abnormalities. There's not usually subarachnoid, aneurysmal subarachnoid hemorrhage, right? It's not because they had an aneurysm. They have a normal or near normal CSF and it's reversible, right? So when you repeat imaging in 12 weeks, it should have gone back to essentially normal, not just stabilized. In CNS vasculitis, we actually rarely see it go completely back to normal. The vessels are damaged and they'll stay damaged. Just another comparison side by side here. I'm not sure that there's a lot else in here, so we'll skip over that. But this is a comparison that actually is from that French cohort we were talking about. So I think that's actually valuable. And in here, there's some other useful info about CNS vasculitis. So I kind of highlighted the good stuff, which is migraines are uncommon in CNS vasculitis. So the headache type does matter, but it's relatively common in the RCVS group. Postpartum, not a known trigger for CNS vasculitis, according to this cohort. Vasoactive drugs, way more common in the RCVS group, but we still ask in CNS vasculitis. Nasal decongestants, as I said, that's something we care about for our CVS as well. There it is. All right, and here's that clinical piece that I had mentioned at the beginning. Thunderclap headache is rare in CNS vasculitis, but it's incredibly common in RCVS. And if it's recurrent thunderclap headache, which is relatively frequent, so almost 90% of RCVS, that was not seen in this cohort of CNS vasculitis. So that gives it a really strong positive predictive value. Of course, it's not perfect. These are always small numbers, but the type of headache does make a difference diagnostically. That is a useful clinical tool. Just a very brief side note on amyloid. There's kind of three subtypes: cerebral amyloid angiopathy, amyloid beta related angiitis, and cerebral amyloid angiopathy related inflammation. So I hope someone fixes up this language at some point. But the idea here, so just starting with CAA, this is amyloid beta depositing in the media and adventitia of cortical and leptomeningeal vessels. It usually causes hemorrhages, and it does not respond to immune suppression. It is a non-inflammatory vasculopathy, but it does involve the arteries. Okay. ABRA, amyloid beta related angiitis, is an angiitis, right? It has inflammation of the arteries themselves. It is angiodestructive, right? It damages the blood vessels. It is vasculitic. It is transmural. There is often granulomatous inflammation. And in that way, it has a lot of the same biopsy features as the granulomatous subtype of CNS vasculitis. In fact, these used to sort of essentially be grouped together as the same thing. This does seem to respond to immune suppression. And same for CAA-related inflammation. This is, you have amyloid beta deposits, and there is inflammation, but the inflammation is not specifically of the blood vessels. So amyloid deposits without inflammation, that's CAA. Amyloid deposits outside the vessels with inflammation, that's CAA-related inflammation. And amyloid beta-related angiitis, where your amyloid is deposited in the vessels and causing inflammation. All right, so we're kind of closing in then, last 10 minutes here. We'll talk a bit about treatment. And this was published, now it's 10 years ago, but I think there's a lot to take from this. I think it is largely reflective of the literature. There's an update that I'll give you in a moment, but essentially they give the perspective that if it's small vessel disease, you try treating with prednisone alone and see if they respond. And if they don't respond, then you proceed with cyclophosphamide or some kind of other steroid-sparing agent. If they don't respond to that, you try another more aggressive steroid-sparing agent. If you are a large vessel disease, they usually induce with prednisone and a steroid-sparing agent at the same time. Okay, this is mostly eminence-based rather than evidence-based, but this is sort of how they split it. Small vessel seems to be, in their clinical impression, more steroid responsive. Now, when we went through the clinical subtypes, we didn't actually see that there was major differences in clinical outcomes based on the histology, based on whether you're biopsy positive or biopsy negative, or based on angio positive or angio negative, which may be essentially the same thing, but we didn't see major differences in treatment. So I just took a quote from a more recent article that's actually worth a read. So it's New England Journal 2024, Salvarani, so same author. We typically initiate cyclophosphamide treatment in addition to glucocorticoids in patients presenting with multiple infarcts, necrotizing or granulomatous vasculitis, and involvement of medium to large vessels. Okay, I'm not sure that that has entirely followed from their biopsy result clinical subsets, where they said, sort of regardless of your biopsy result, clinical outcomes are similar. Anyway, so I'm not sure it totally follows from that, but that's their clinical practice. So they use cyclo essentially when people are having strokes and to a degree based on histology subtype. All right. We use glucocorticoids alone in patients with small vessel vasculitis, particularly those with lymphocytic vasculitis and no infarctions who generally have a milder disease course. So I think this is sort of inside baseball, right? They're the ones running the cohort. I think that even though their published data does not entirely support a more mild or indolent course for the lymphocytic group, nor does it prove that lymphocytic is more likely to be small vessel or small vessels more likely to be lymphocytic. This is their pattern of practice, and that's sort of been reflected in their 2015 paper, their 2024 paper. So this is more eminence, I would say, than evidence. I've not found really compelling literature behind this. I think that's sort of why they say typically, so that they have a little bit of a way out. So this is kind of a bit of a generalized summary. There's no RCTs that exist to guide therapy. No surprise, this is super rare. Aspirin is sometimes prescribed, but I usually make that decision in conjunction with stroke neurology about what's their likelihood of having a bleed. Is there value in the aspirin? Are there vessels that are stenotic and like threatening to occlude? That's sort of where I see them using aspirin or even heparinizing patients, where they're like, this artery has incredibly low blood flow. If you drop their blood pressure, they will infarct the MCA. That might be quite appropriate to put them on that temporarily, but just reflect that this is not atherosclerotic disease. It's just not the same process. Okay. Treatment primarily is based on expert opinion, the cohort data that we've talked about, case series, and there's very limited data for any of the other steroid-sparing treatments, but there's not none. And this is probably going to affect sort of how I treat. There's evidence from 2 observational uncontrolled studies that mycophenolate's effective as cyclophosphamide in inducing remission in patients with severe disease. That's not great evidence, but it's what we have. It may represent a less toxic alternative to cyclo. I agree with that. Mycophenolate's also effective as maintenance. I agree with that. So there's reason why we might use this. Ease, it doesn't seem to be worse than cyclo. It's less toxic. We can start it whenever we want. You don't need special nursing. It's pills instead of IV. So that's all good. There's a new paper that came out on Actemra, which you see for giant cell arteritis, or tocilizumab. This was 3 patients with relapsing disease. All 3 achieved long-term disease control with Actemra. So that's all we know about that. That's not very helpful. Rituximab is actually what's going to come up with some frequency. So in this case series, Salvarani, the same author as before, 5 of 6 patients showed improvement, and they reviewed the literature and identified 7 additional patients, of which 6 had improvement with rituximab. So the available evidence is supportive. It's really modest, really, really modest. Maintenance therapy, thankfully, has a nice review from the French group that this is patients who have achieved remission after induction. They're followed for over a year. 50% received maintenance therapy. This is all retrospective, so they weren't randomized. And the maintenance was kind of random. Methotrexate, AZA, MMF, these are common disease-modifying agents. Relapse-free survival and good functional status were their outcomes. In the maintenance group, where they got something to maintain disease control, almost 70% had relapse-free survival and good functional status. No maintenance, only 20%. Small numbers, retrospective, but this is still helpful information to guide treatment. Purely looking at relapses, only 20% relapsed if you were on maintenance medication. If you were on no maintenance medication, it was almost 50-50. So I'm not seeing a great deal of reason to avoid maintenance treatment, which is also why I find it a little bit harder in those small vessel vasculitis patients to make a good case based on the evidence to treat with prednisone alone and no other agent, because are you or are you not going to put them on maintenance? probably would. So starting the MMF now versus when your pred is low, I'm just not hearing it. Like I'm not catching the logic in the literature there. So we're coming to the end. We got 3 minutes left. Prognosis is actually good. So response rates are high, 92%, or 80 to 92% across the two cohorts. Mortality is relatively low. So this is a disease that if you catch it, you can be very helpful. We usually do maintenance for about 2 years, then taper off. And just back to our case for a moment, this gentleman, he had a biopsy. It showed extensive transmural granulomatous inflammation. He had extensive workup for a secondary cause that all came back negative. We diagnosed primary angiitis of the CNS. He also, it turned out, had latent TB, so we treated him for that too. We don't think that was the cause. We gave him a pulse, cyclophosphamide, and maintenance with mycophenolate. Kind of pretty standard approach. I saw him a week ago. He has been off treatment for about 2 years, and he's doing really well. And I would say his functional status is good, and he's not remitted. He's in steroid-free remission. So I think that's a good outcome. We never consider these patients cured, but I think that ended up going well for him. All right, so that's a lot of content. Curious if there are any questions in maybe the last minute that I have you.
When you're deciding on biopsy and then neurosurgery reviews the scan, if the non-dominant frontal lobe doesn't have very much disease, do they still try to look for there, or do they kind of look for the more active area, even though maybe more quote-unquote scary?
I think that's sorry, just for people online, the question was about if you have a patient where the disease is active, but in harder to biopsy places, would they still try and biopsy that, or would they go for the non-dominant frontal lobe, as we said? I think it's a great question, but it is going to be very case by case. Kind of just like depends how high the morbidity they quote for that area of brain to biopsy. Barry?
Excellent review. And I mean, it really highlights how dedicated you have to be to look very closely at all of these issues. I guess the question I have is, we had the mimickers. I'm always concerned about underlying infection that we don't recognize. Tests that we're not able to, just aren't in our wheelhouse. People are now traveling from all over the world. In the case, in reviews from the Mayo or from the French, did they talk about any cases that they found had underlying infection that they actually initially diagnosed in this sense?
Yeah, so Barry's comment was that I'm awesome. Thank you, Barry. And then his question was about those cohorts. Did they kind of uncover in their process other infectious diseases? The cohorts excluded anyone where they did find infection. So that kind of the establishment of the cohort, or like cohort of patients referred for query CNS vasculitis, which is a cohort I think would be even more interesting than the cohort of people with definite vasculitis. That is not something that that I have seen them publish on. They definitely, there's only like a handful of authors who work in this field, and they do have a lot of papers on like the mimics of CNS vasculitis, but I don't have specific numbers. I think that meta-analysis was kind of maybe the closest to answering some of that question, because it's the biopsy result in groups referred for CNS vasculitis or groups referred for cryptogenic neurologic disease. And so those are sort of the group you would see cryptogenic neuro stuff. Maybe I'd see more query CNS vasculitis. So that applies to you.
Have you had any where an underlying infection was found in the workup?
Yeah, so the question was, have I actually had an infection found? So yeah, so VZV is kind of a known trigger for a VZV vasculopathy. So the initial concern is that it's CNS vasculitis, but then the neuroradiologist and stroke neurologist are like, this is a suspicious distribution. It's kind of a beaded, unilateral focal territory. And then VZV ends up being the diagnosis, but I haven't had anyone, or I had one TB. who had a bunch of TB tuberculomas, where the initial concern was vasculitis. All right, I think I don't know if I don't actually know how to monitor online, so.
There's
oh, there you are. Okay.
There's Daniel, there's many there's multiple commendations for you. And then Dr. Hansen put a plug in for data 2 patients that present thinking about data 2 when presenting with cryptogenic stroke. I think I could see the presentation multiple times and still continue to learn tremendously. So thank you.
That's very kind of you. Yes, data 2 is super important. The mimics are extensive, and I think probably mimics of CNS vasculitis is its own separate talk, and data 2 is an important consideration there. So thanks, Dr. Hansen. All right, maybe we'll leave it there. We're right on time. So thank you very much for coming, and take care.